Well, welcome. Thanks for coming to our little soiree here, talking about HTM Department Secret Sauce. You have the Three Musketeers here. Um, Earl Morris, Mike Busdicker, and myself. Um, our goal for you this afternoon is we hope that you leave here with a little nugget that you can put into practice for yourself or just get something out of our little discussion. Now, our discussion this afternoon is going to be an open discussion, right? It's audience participation. So we like to hear, again, because we don't have all the nuggets today. We hope that I see some guys with hair like me in the audience. So I bet you they have some nuggets, and I see some folks in the audience with some distinguishing gray characteristics. I bet you they have some nuggets. So I was just in Arif's presentation, and he started his discussion off by going through years of experience. You know, how many are 0 through 10 years experience? 10 through 20, and then 20 plus. Boy, when 20 plus, there were quite a few hands that went up in there. But we're hoping that the 0 through 10, like Earl, will continue to stay in this career field, grow in this career field like Mike and I have and others in this audience have. So today we're going to talk about a little bit of diversity amongst the types of programs. And really, hopefully, if there are some 0 to 10 through 10s in here, they get some information about the differences with regard to size organizations and the different hats that ones wear. I had dinner last night with some of my friends from Mayo, and there's an awful lot of FTEs in the Mayo, and so the lines sometimes get drawn in the larger organizations, while somebody in Harrison County Hospital in Indiana might wear quite a few hats. So the first thing I'm going to do is we'll introduce the panelists. So Earl, I'm going to let you talk a little bit about yourself. Harrison County Hospital. Go ahead, Earl Marks.
Okay, well, I'm Earl. Harrison County, Indiana, which is, everybody knows where the Kentucky Derby is. We're 20 minutes from there. The 25-bed hospital. I've been in the career for a little over a year and a half, almost a year and a half. I was basically handed the keys and said, good luck, because the guy that trained me was only working 2 days a week. And so that's what I got for the last 2 years. Then I went to CBET college to finish up my degree. And I also am one of the county coroners in my county. And I pretty much do anything and everything from beds, IV pumps, imaging like for first call. Basically anything a patient touches, I deal with by myself because I have no backup. So there's that.
You need no backup.
Yes, I need no backup.
Mike.
Certainly, thanks. And yeah, with Earl, I was like, I never thought about being the director or the the manager or the person, the biomed person, and the county coroner. I mean, that they might fit in there together. But anyways, Earl's very nervous, but he's doing a great job. And he'll do a great job. So we appreciate him being here, and he's probably my next hire out in Salt Lake. So he'll be leaving no, I'm just kidding. No, I'm not kidding about hiring him if he needed the job. Anyways, Mike Busdicker, I'm with Intermountain Healthcare. Actually, Intermountain Health, we took the care out of healthcare.
Yes.
So it's Intermountain Health. And we just recently merged with Sisters of Charity Leavenworth. So we now are 33 hospitals across 7 states, 385 clinics, about 4,700 licensed beds. We are actually going to open our newest children's hospital in January in Lehigh, Utah. And we're building a replacement hospital in Wheat Ridge, Colorado for Lutheran Medical Center. That'll be opening in August 2024. It says, we've got a large life flight program. It's actually, on there it says 6. We actually have 28 aircraft. So we've got 16 rotary wing and 12 fixed wing aircraft. We bought an organization called Classic Air. So when we bought Classic Air, it added to our life flight fleet. And we take care of all the medical equipment on there, on those aircraft as well. So we've got them stationed actually throughout the country. We even got one in Puerto Rico. We haven't had any lack of volunteers to go there and service that equipment. But actually, we have them send it back to our depot and then transition that out. So I've got 180 FTEs in the HTM department. I've got 5 area clinical engineering directors and then managers at some of the sites as well, including our home care equipment inventory. We're a little over 200,000 devices, and that includes 9 dedicated technicians in home care, because we got 35,000 devices in our home care inventory as well. So great organization to work with and growing. So, and it is a privilege to be here with new people in the field as well as old people in the field like Al Gresh.
So there you have the small hospital, 25-bed hospital, rural hospital in Croydon, Indiana. And then you have Mike at Intermountain with 4,700 acute care beds. And then maybe you have me kind of in the middle, maybe closer to Earl's side. But some people are probably thinking, wait a minute, Nowak, where are you? What do you mean you're at Arkansas Children's? So I was formerly with Universal Health Services out of King of Prussia, Pennsylvania. We had 6,200 acute care beds across the hospital. But after 10 years of probably traveling 3 weeks out of 4 weeks a month and working 14 hours a day, I decided to get my life back, and I go to Arkansas Children's Hospital, which is a wonderful, wonderful facility in central Arkansas. At Little Rock campus, we have 336 beds, and then we have a small campus to our northwest in Springdale, Arkansas, Arkansas Children's Hospital Northwest. In Little Rock, we have a level 1 trauma center as well as a level 4 NICU. We own 2 helicopters that travel the state and surrounding states as well. So we sometimes dip into Texas and Oklahoma City and Missouri, Tennessee. So it's a pretty busy hospital. Its coverage area is pretty large. And I threw that last bullet point in there because if you're in our hospital, and I like to walk around, I asked the wireless guy or the audio guys, I need a wireless mic. He said, we don't do wireless in this, but anybody that's been to one of my presentations here before knows I love to walk around. Anyway, so I'll try to talk loudly so that they can hear me on the microphone. But so if you're walking around Arkansas Children's Hospital, you'll see adults going through the hallway on stretchers. So we have the only burn unit in the state of Arkansas. And a lot of times there's adults who might have an 83-year-old grandmother there that burned herself on the stove, or you might have a young child who got involved in fire. So that, and of course, like most children's hospitals, you might have cystic fibrosis patients, and a lot of times they get managed for a long time of their life, into their 30s, and they still see that pediatrician that has been managing them all those years. So it's a great place to work. We do research there. We have a whole research building where our physicians are trying new technologies and kidney transplants, liver transplants, heart transplants. So it's been a fun go for the last 2.5 months at Arkansas Children's. So maybe I'm a kind of a mid-size. I'm the lower end of the mid-size group, and we're going to talk about that diversity today. And you heard a little bit about it as you heard Earl and Mike talk about some of the responsibilities. Earl wears an awful lot of hats at Harrison County Hospital. And, that presents its own types of challenges. the challenges of vendor service and managing vendor service and parts availability in something that rural. And to just the negotiation of some of those contracts, right? The economies of scale that Harrison County versus an Intermountain. So, some of those vendors would certainly like to have that volume of business that Mike Busdicker provides them. So some of the challenges in the diversity of size, well, Earl, is there any challenge in staffing at Harrison County?
I have 0 problems with that.
Mike, how about you?
Yeah, so with 180 FTEs throughout the organization and across 7 states, we've got 3 hospitals in Montana, there's 4 in the Denver area, 1 in Grand Junction, and then hospitals spread out from St. George, Utah, all the way up to beautiful Burley, Idaho. If you've never had an opportunity to be to Burley, Idaho, you're not missing much. But we do have, so we have our in-house staff at those facilities, as well as I mentioned, we have 9 that are dedicated to our home health organization. 5 of them are on the durable medical equipment, Mike, or is it the other way around? 4 on wheelchairs, 5 on DME. Okay, and I say wheelchairs, but actually what we're talking about is power chairs.
Yeah.
And these individuals, they are, I can't say that they're my favorites in the organization, I guess, but the things that they do in building these power chairs for kids and adults, and in fact, they're probably today, they're at Shriners Hospital today, dressing up power chairs to look like dinosaurs and fire trucks and things like that for the kids at Shriners to be able to trick or treat. And these guys are just amazing. And then we've got our field operations, so our imaging service engineers that are on the road covering multiple facilities, as well as I have a central depot where we do mobile medical devices. So if we've got infusion pumps, compression therapy, things along those lines, if it takes more than a half an hour to fix, the hospital send it to the depot, and then it's fixed and repaired at the depot and sent back out from there. So we have our own central depot that takes care of those things. We've got field operations for things that we don't have enough volume of devices in one hospital to train somebody. We train somebody on these devices to handle multiple, like surgical lasers, even hospital beds. We run the hospital beds from a field service operation. So we've got really, when you look at the technical capabilities of our staff, it's all the way from apprentices that we've got in to CE Tech 3s to imaging engineers 1, 2, and 3s. So all across the board. So keeping that staffed, we have 8 openings right now, but I've got, out of my 180 members of the team, there's probably 50% of them that are retirement eligible within the next 5 years.
Yeah. Yep. Mike, you just made a mention there before I go into some of our staffing challenges in Little Rock, but hospital beds. How many departments do hospital beds? Yeah. So I was in a presentation a little bit earlier today, and they used an example of hospital beds, and it was about risk. We talked about risk in that presentation, and we do hospital beds as well, and I did those at UHS as well, and people are like, oh my gosh, give that to the maintenance department. Well, the maintenance department did have that previously, and unfortunately they were spending about $500,000 a year outsourcing that service in just one region that was involved. So the thing with hospital beds is how integrated to the care of the patient they are, right? So we have a hospital bed, we have pressure ulcers to worry about on the hospital bed, we have exit to worry about, patient falling out of the bed. We have scales on most of the beds. What do we do with scales on the beds? What does the physician use the scale for? Weight-based prescription medicine, right? They're giving medication based on the weight of that patient from that scale on the bed. Man, if that scale's not working properly, or it could kill the patient. That's pretty dramatic, but that's the truth. They could make a wrong calculation because the weight is incorrect. So beds are, if you're not doing beds, it's a great way to grow your department. It's a great way to grow the skill set of the team and provide additional value. And what I always talk about is weaving that web into your organization so that, when you're involved in the organization, it's hard to separate. It's hard to break apart the fabric when you're tightly woven. So think about those opportunities, and I appreciate you bringing that up in your.
Yeah, and I think if you look at it, I mean, when I started in this industry 42 years ago, when you look at it from a technology standpoint, beds were furniture then.
Yeah.
Not anymore. They're clinical devices now. And there's a lot of things that have progressed through that, through that technology advancement piece. And the other thing is that from our depot, like our guys that work at the depot, our staff, say guys in the general term, but our caregivers that work in our central depot, we know that, they're not going to stay there because they're not going to want to spend the rest of their career, they're tech ones, and they're not going to want to spend the rest of their career working on infusion pumps. But we utilize it as a career progression and a stepping off point. So we can put an apprentice in there and build them up. We can put a tech one in there, give them the skills and capabilities, and then we can move them into our acute care hospitals or settings and advance their career, where we just, we continue to steal people from Monty's college. So.
Yeah, that's great. But back to staffing. So in Little Rock, I've been fortunate in Little Rock, even though I've only been there a short time. The staffing has been very strong. We have a great team there, but there's not many facilities in the Little Rock area, so I don't do a whole lot of stealing from other facilities. That's very limited. But we do have Falcon aircraft at the Little Rock Airport. And we have a lot of technical staff over at the Little Rock Airport working for Falcon Aircraft. And that's been a very good blessing for our team, because we do go over there and cherry pick some good folks from there and transition them into healthcare. And it's worked for us. And I've seen that in other locations, from a staffing perspective. I don't know if...
What I think, Earl, if you could talk a little bit about the CBET college and what that entailed and
Great.
How you went through that, because we're at my organization, we're working directly with Monty, and we're talking about what we can develop from an organizational standpoint in developing and building that pipeline. So, we've got somebody here that has firsthand knowledge of that program.
I mean, it took me, I think, a year and a half to get through the entire program, but I had previous college credits, so that helps. Basically, I felt like it gave me the building blocks to what I needed, plus my hands-on experience that I was getting with the guy that was there a day and a half a week. And I also went to a hospital about an hour away, Tell City, and worked with somebody from TriMedics for a few weeks for like an internship. So, I mean, the more hands-on experience with the education piece that you get, I know that I think they were going to do a lot of VR at CBET, right? Virtual reality. Like, I don't think it was a big thing when I was there a couple years ago.
So is that TriMedics experience? Was that through CBET?
No, I just met, I knew the guy at the other
Oh,
hospital.
okay.
And I was like, hey, can I come over and work with you for a couple weeks?
But I think that's a great, I think Earl makes a great point. For us that do have programs, it is a wonderful opportunity to work with schools like Monty has, and other schools or tech schools, or even though they may not be biomedical programs. When I was at UHS, we did pull some folks out of tech schools, bring them into our hospitals as interns, and let them build their skill set for succession planning. That is such an important piece of the puzzle. Succession planning, like what's Harrison County? Like, Earl, what happens if Earl goes away? Or
Guess they're gonna be in a pickle for a little bit. Because the guy they had before me was a contractor, and
Oh,
I worked in the IT department, which I was there for 4 years in the IT department. They came to me and asked me, hey, would you like to do this as a growing stone? And I was like, sure, let's do it. I mean, as an opportunity, I saw it. But I've got 15 years of IT experience behind me, which everything, as we all know, is moving technology based. So I think that's going to help me with knowing the IT director and everything. So it's a lot easier to get some projects completed going forward.
well, that's a great segue into our next topic, which is standardization of medical devices. And, you mentioned IT. Most of the devices we're buying today are touching our networks. And I sometimes get very frustrated if I come to meetings like this, or the Amy meeting, or a regional meeting or something like that, and I hear one of my peers say, oh, I hate the IS department. The bane of my existence is the IS. And I get that. I can understand that from some respect, but we have to learn to work with those folks. They are going to be an integral piece of our relationship within our institutions. They're going to be our customers. They're going to be our providers as we try to connect more and more medical devices onto, quote unquote, their network. So, I was just in Arif's presentation, and he touched upon medical telemetry, and he spoke about WMTS. Well, I'm a very anti WMTS guy. I hate it. I think it's silly. I think it's the future is a standards-based medical telemetry, an 802.11 product, and there are a few providers out there that have 802.11 products. I had 2 different manufacturers when I was at UHS. I never got a phone call. Extremely reliable, no problems on our network, very, very good devices. So my goal, speaking of standardization of devices, forward going with medical telemetry, I want to get an 802.11. I want to get a standards-based product versus a WMTS product. Even the bedside, right? Your module that collects all of the physiological data from the patient can go wireless today. Some of the Philips X3s wireless. GE came out with a product that I suspect will eventually go wireless. It's not wireless yet, but I suspect it will go wireless. There's other vendors. Nihon Kohden has 802.11 telemetry. So, and the same module, multi-parameter modules, you just pull it out and you go with it. And it never stops communicating to your Epic, to your Cerner, or whoever EMR. So there's no interruption in data. And that's what your clinicians want. They want to see all of that data. I know you can get there and you can dock it and it's going to download. And I don't know how many people have had problems with when you dock it and it goes into Epic or it goes into Cerner and it doesn't populate. And I have. So, I mean, it's problematic. However, when you're going seamless and you're using a standards base, it's hitting your wireless network and you have enough, everybody's going integrated with pumps, infusion pumps. Your wireless network, when you're going robust, when you're going with infusion pumps, has to be robust. So your institutions are getting to a point where you don't have to worry about a lot of dead spots in the technology. Medical device standardization at your place?
Right now, it's the Wild Wild West.
Wild Wild West.
Because
And what drives that, Earl? What drives it? Is it physician-based or?
Some of it's physician-based, but I think a lot of it is cost. 'Cause small hospital, we've got IV pumps from 2005 that are still in operation. Some of the stretchers are from 1999, like they're stamped with 1999 on it. So I'm working with a bunch of old equipment. Right now, we're looking at neon coating for the patient monitors, and I think striker for the beds. So we're going there, but it's taking time.
No Lynette for beds?
No, we got who's they picked up for? I think they picked up those for stretchers.
Okay.
They like those stretchers better than the beds. 'Cause they look like little coffins. They wouldn't have beds. Sorry if anybody's for Lynette.
That's okay. At the Children's Hospital, we had a surveyor that came in our cribs for children. The surveyor looked at the cribs and they said, they're baby jails. So I just spent $750,000 replacing baby jails. Because the other ones have flat bars, so they don't look so much like a baby jail instead of round bars. Mike?
So I think from standardization of medical devices and taking a look at it, there's a number of different things that, the benefits are there. And one of them, of course, is volume buying. So volume-based purchasing, you can get better discounts and better pricing. You can ensure the training is included in that piece of it. And, it was interesting when I first went out to Intermountain and started working for Intermountain. Standardization of medical equipment was not something that was high on their priority list. And they did a lot of buying based on physician preference. And what we ended up starting to do, and somebody once told me, if you're not involved in the capital planning process, you need to insert yourself in there. Don't be shy. Insert yourself into that process, right, Al? And become part of it. And one of the things that we took a look at, and the organization actually supported it extremely well, is we started to take a look at and saying, you know what, we've got a hospital here that has a cardiac cath lab that has all of these bells and whistles on it. And we've got a hospital that's 25 miles away that wants the same piece of equipment. Why are we doing that? Why are we not putting that one with all the bells and whistles in this hospital, which does a whole lot more cardiac caths, and put something lower end in this hospital because we don't need everything with all the bells and whistles? Well, the hospital down the road has it. Well, so what?
They become competitors in their own.
Yes, become competitors
in their own family,
in their own system.
Yeah.
And then we had physicians that would say, this is what I want. Well, that's not our standard. Well, this is what I want. That's not our standard. And then they would come back and say, if you don't give me what I want, then I'm going to take my business elsewhere. And finally, we got organizational leadership, including the CEO, to say, sorry to see you go.
Yeah.
But good luck.
Yeah.
And, and that changed the, their outlook a little bit too. Then they were a little bit more willing to accept the device standards and what we were using standards. Now, we didn't go out and set those standards without having their input into the process. And our supply chain, when we pulled together a committee that's going to look at new technology or replacement technology, we include physicians on that committee as we go forward, and clinical personnel as well. And each has got, a vote in going forward, but we do standardize on that equipment, which makes things so much better, as well as we utilize our own nurses and clinical caregivers as a float pool. So when they go from hospital A to hospital C, the equipment's the same.
Yep.
So they don't have to have training on that equipment because it's the same thing that they were using at the other hospital.
So I like to, it's the Southwest model of healthcare, right? Southwest has all 737s, the type rating for the pilots, it's all the same type rating. So the pilots can get in from, a 500 to a 700 model, and it's the same type rating. It's the same thing with standardization. And by the way, remember I said this is audience participation. So if you have questions or you want to come back at us with maybe something that you feel differently about what we're saying up here, please jump in and enjoy the ride. So standardization of medical devices is a big deal. Go ahead, Al.
Money that you save by leveraging volume just on the acquisition is immense, but you have no idea how much it impacts cost of service. Because time to negotiate literally anything is when you still have those capital dollars in hand.
Yes.
So going on to the next bullet point, service education. What it comes down to is if you want to do business with Intermountain Healthcare, with whatever organization you work for. This is how we do business. We service things ourselves, and we expect you to support that.
Yep.
Right? If you don't, we're happy to do business with somebody else. That's who has all of the levers. You can negotiate things like parts discount and HTM labor discounts and a number of different things, including like
Service keys and education.
echo what Mike said about clinical competence. Yeah, you have your own flow school system, but the turnover, clinical positions within healthcare organizations. So if you have standardization of devices across the entire system, really that becomes a patient safety.
It does. Yep.
Well, and it helps in the capital planning process as well. We can take a look at our entire fleet of patient monitors and we can put together a 5-year plan to replace that fleet of monitors. And we don't have to do it all at the same time. That's why we scheduled it over 5 years. And while we're doing that, if we're replacing the monitors in this facility and we get that done, we may have monitors in this facility that's further down the road that may be a little bit older or not from a technical capability. They may not have the bells and whistles that these other ones have, and we can reinstall those here and then get rid of those. And so it helps in that capital planning process as well.
Cool. Next topic, service keys and education. Challenges. I think the challenges are getting more and more difficult from that perspective. I think the OEMs are certainly putting hooks in there that are becoming more and more difficult, especially from the service contract side. If you don't buy the service contract, then the parts are going to cost you just as much as or more than the service contract. The service keys, I think, Al and Mike and Earl, we've made a good point about the time is when you're acquisition. The time is when you have those dollars in your hand and they're foaming at the mouth for signing of the PO. They want the PO, but you're in control. You're in the driver's seat at that point. And you know what? Some of them may decide, hey, I'm going to back out. I don't want to do business. That's fine. You do have choice in healthcare so far. In the United States, you still have choice with who you want to do business with. But a business partner that's respectful of that will continue to do business with you.
Yeah, and I think it's very important that they know that up front. So going into the process, and I'll tell you, I had a vice president of supply chain one time that during a course in class, he told me, he said, listen, there is a difference between a vendor and a supplier. A supplier is somebody that works collaboratively with you to ensure that there's a win-win. Win on their side, win on your side.
Yeah.
And when that occurs, the patient ultimately wins. And so does healthcare cost and everything. So they need to understand that we know they need to make a profit.
Yep.
In order to survive, but we need to do this in order to survive. So we want you to be a collaborative partner with us, and you become a supplier. Other organizations, vendors, they're like popcorn and hot dog vendors at the ball game. They exist on a
transaction.
Yeah, transactional only basis. Do we need them? Yes, we need some of those, but we need more suppliers than we need vendors. And
that's what, I think that's a great point. And I'm sure, Earl, you in this situation as well. I always talk when I am negotiating with the vendors, I want a relationship. This business has to sustain itself on relationships, because as I say to them, I want to know when the lights go out and I turn around that somebody's behind me, that they're there to help. And again, it's that just as the patient focus, right? It's not a Mike Busdicker thing or Intermountain thing. It's a patient thing that we're trying to do. So great point. Andrea.
To your point, though, we need to sort of develop a process. our organization, supply chain does all the negotiations. They have to be your partner. They have to be amazing. Whereas before, it's like, okay, so-and-so, they're ordering that, it's ordered, it shows up at their doorstep, right?
Yep.
Hold the phone. Did you ask about, service education? Did you ask about extended warranty? We can't afford it, et cetera. So again, making sure you have those partners so that when they do go order or get approved, they come to you first to say, okay, what do you need? Make sure this is, and are you ordering the right stuff? Are you ordering the right accessories that can go with it? Instead of, they're just, they give you, oh, we need this. Like, well, you don't need 10 line items.
Yep. Andrea, you bring up such a great point. As you're talking to us all about that, there's stuff running through my head. So that relationship aspect again, even within our own organization, right? I talked a little bit about the IT department when we first started. Andrea's just talking about supply chain. They have to trust you. They have to believe in you. You have to earn that. It's not given. So you got to give them opportunities to develop that trust in you, to develop that relationship in you that, hey, you're going to be there for them just as much you want them to be there for you. So, if there's some of the youngsters in here that are in the organization, it is about relationships. It's about, there's some of those things where, engineers, technicians, they stare at their shoes when they're talking to the nurse in the unit. You got to have a little bit of a dialogue, a personal relationship with some of the folks in your facility to be effective.
And I completely agree. I'm on board 100%. But the other thing is, once you develop and build that relationship, you need to make sure that there's a line drawn in the sand as well. And that is, when it comes to service decisions on new equipment, it's not the supply chain's decision to make. It's not the clinical department's decision to make. That decision lies with HTM. That is our decision to make on whether we're going to do it in-house, contract it out, or however we're going to approach that. We'll take input from all of those others, but when it comes down to it, unless I'm overruled, that is my decision to make. And the other thing is, you talked about HTM technicians, they're introverted by, they're introverts, but, and there are some extroverts, but you can tell the difference because an introverted engineer or technician looks at their own shoes when they're talking to you. An extroverted engineer looks at your shoes when they're talking to you.
Al.
You have to have relationships with physicians as well. A lot of decisions are physician driven, but if they trust you and you sit down at the table with them and say, look, I want to get you what you want, but you have to be willing to work with me and convey to the vendor that you're open to looking at, okay, you want Siemens, you're open to looking at Shiba or Philips. Or
Yep.
Work with me on that. Because what if I can get you what you want and still have $500,000 or $1 million in our pocket to buy more stuff? Isn't that what we all want?
Yep. Absolutely.
Again, you got to look at their shoes.
And that's where I think it's important, even with, from the supply chain perspective and everything. And that's where, somebody told me one time, if you're not involved in that process, insert yourself into it. Make sure you're part of it. And you may get, or you probably will get pushback from others, but they need to understand that you're the subject matter expert.
Yep.
That's what you do for a living.
But
Really strong. Try to take over Latin.
yeah, absolutely, Rod. Yeah, but what we're describing here too is our staff. Our staff do matter. When we're hiring, it's important when we're hiring, we hire well. Not just a warm body to fill a spot, but and I see Wayne in the front aisle here. it really, it doesn't matter if you're an OEM guy, a third party guy, or gal, or an in-house person. It matters who you hire, the leadership in the organization that drives the whole ecosystem of the organization. What kind of like safety driven are you? Is there a relationship with your employees? I had a OEM employee. Here I am at Children's Hospital. I'm there just a couple of weeks, and our PMs are, believe me, there's a lot of service contracts at Arkansas Children's, but our ultrasound machines are with the OEM, and the OEM is in there doing a PM on a Friday afternoon, and I went over and started talking to this person. I said, so I saw him scanning his carotid, looking at the screen and checking the transducer out. And I said, so do you have a Phantom? He said, oh yeah, I got a Phantom. I said, could I see the Phantom? What kind of a Phantom? I'm looking to buy Phantoms here for Children's as we build our skill set. And he says, well, it's in the car. I said, oh, okay, all right. So I let him go, let him finish the PM. I went to my office, and fortunately, as I'm coming out of my office, he's just finishing up his PM. And I saw my tech grab the ultrasound machine and start heading out the door while the OEM representative is finishing up the paperwork on his computer. And I got his eye, and I said, hey, brought the ultrasound machine back in. The OEM representative left, and I use it as a learning example. Because again, my staff isn't imaging savvy at this point. So he leaves. I get on the ground with all my staff around. They all happen to be in. It's now 3, 4 o'clock in the afternoon. And what did I do? Anybody know what I do when I got on the ground? I pulled the filter out, Wayne. It's clogged. It's got a ton of dust on the filter. So it's like, that's probably the first thing you would do, right? When you're PM, just pull the filters out and just, it's clogged. It was the greatest thing that person did for me, because I demonstrated to my team, who held these folks in regard, right? It's the OEM. They always do it right. They're perfect. I showed them. It matters. It matters who we are and who they are that come into our institution. Because I gotta be honest with you, my team, people are coming in and out of our place, and we don't even know they're coming in and out of our place. So no, guys, they don't care like we care. They're our patients. It's our responsibility. So that was a great learning experience. We're talking about staffing. We're talking about service education. It matters who you hire. Hire the good ones, or bring them up to speed.
And be part of the organization. I did a presentation before a couple of years ago and stuff. It's called Elevate the HTM Department. And the reason behind that is, when you look at your department, they are part of the organization. They are a very integral part of the organization. And they need to understand how what they do impacts the outcome. And that tie needs to be made. So in that presentation, I would ask, how many of you have mission statements? How many of you have a mission statement for your department? And people would raise their hand, and I would say, is it different than the hospitals? And I would tell the people that if it's different than the hospitals, take it off the wall, tear it up, and throw it away. Because your mission statement shouldn't be any different than the hospitals. As a leader, your requirement as a leader is to ensure that your staff, that your caregivers understand how their job ties to the mission statement. Vision statement can be different, the aspirations can be different, but the mission should not be different. It should be exactly the same. And when you insert yourself into things like capital planning, into the supply chain, into safety events, anything like that, when you insert yourself in there, you become part of that team that's helping the organization drive forward and reach their objectives, goals, and their mission. And you'll find that once you do that, you won't have to go insert yourself anymore. They'll come to you and they'll say, hey, we want you to be part of the solution. And we want you to have a seat at the table. And you'll elevate your department to that next level. No longer are we just a repair shop in the basement located next to the morgue. We still may be in that office, but that's not our department description anymore.
Sometimes it's beneficial to have it so close to the morgue, right, Earl? That's very correct. Were you going to jump in and say something? Did I see you? Were you going to say something in that? No, you're good?
Yeah.
Okay, all right. Let's move on to the next topic, cybersecurity. Challenges in cybersecurity, again, in programs of differing sizes. What's Harrison County doing?
Well, up until a year ago, I believe we had no cybersecurity, but there's been a couple hospitals in southern Indiana that's been attacked. So we started implementing on the IT side. There's nothing IT related right now in Biomed. So we went to micro-segmentation. So everything on the network is segmented to, it can only get to certain things. So that's going to help mitigate if there's any kind of risk that happens.
Do you have like ICU monitors going to an EMR and that kind of stuff?
No, none of that.
Okay.
We're really old.
Yeah. Mike?
I would say from our standpoint, it's just really the sheer size and the number of connected devices. So, and controlling that and ensuring that everything is done the same way at every facility. And we're looking at that transmission of data and information as well as the capital planning process to make sure that we've got updated devices and those that are not updated are segmented. And really, because everything's starting to communicate. I mean, you look at the bidirectional communication between hospital beds and nurse call and things going to the EMR, and now start throwing home care in there. And when you start, you know, we're installing dialysis machines in patients' homes, and we're installing other devices in patients' homes. And how is that data being transmitted between the hospital, the EMR, and a patient's home when you're using their network? And, you know, just some of those challenges as well.
And Mike, I'm going to get to you. Mike brought up a great point. Your installation, patient monitoring installation, in something like that, that you have, you know, maybe you're installing 35 new ICU monitors in your facility and the OEM's doing the install, right? Please go behind and check the configuration, especially the network configuration of those devices. One of the things that we did when we first got our IoT product on the network and listening to the network, we were looking at the bedside patient monitoring network, and guess what? We had devices, some had the appropriate ports identified and communication ports going on. A couple of them were wide open to the internet, wide open. So whoever the installation team was, they probably had a couple of guys that were very good at it and a couple of folks that were probably very poor at it, because we did find a few of those. Dangerous situation where that was wide open to the internet. Mike Powers.
So, my experience is medical school, graduating physician, that congratulations, we'd like to have a little relationship with you and manufacturer ABC. Here is a free Bluetooth enabled ultrasound probe. You can be Lucy on the side of the street doing psychiatry for 5 cents, but radiology for 5 cents, and scan people and send it to your phone. Those are free. You walk in the door, physician wants to use their free ultrasound probe that's networkable and sends data who knows where, maybe to their phone, maybe to a corporate owned phone, maybe to who knows where. That's one of those things that comes in, and even if they're not giving them for free, they're less than the capital cost. So they can still walk building a networkable device, not getting caught by any kind of capital considerations or flags or plan for or implementation guides created. Look at some of those things that are different price points, be they free or otherwise, that don't quite meet that capital component, because those are also huge inroads for attacking.
Yeah, and I think, so to Mike's point as well, is to ensure that you've got a good handle on the equipment coming in and going out of your hospitals. I mean, how many people look at devices that maybe you're going to send out for repair that contain PHI? Do you wipe that before you send it out? Or does it send to the manufacturer for repair and it's still got PHI on it? The other thing is, what about remote connectivity? If you've got VPN access into Nurse Call or whatever, and Baxter, Hillrom, well, they're owned by Baxter now. If they say, you know what, we've got 5 techs and we want them to have remote access and support to your system, so after hours they can get into it. Well, 6 months down the road, do you check with that? Do you check with Baxter yet and say, are these 5 still employed? Or did 2 of them leave and they still have access?
Yeah, and you know, if credential wise, are they distributing the credentials amongst the, in that case, Baxter team? You know, all of that is, quite frankly, I take it on as my responsibility, right? It's not IT's responsibility. It has to do with the medical devices that we support. But I work with my security team at the hospital because they're the ones that provide the credentialing. And they, you know, where I'm at now, that is very tight. We just had issues with Baxter folks who we changed the way we managed that. And all of a sudden they found out that they couldn't get into our system. So it was great. They all had to get signed up again to get into that. You know, you have outside vendors that come in and access your network all the time. We had somebody with a gateway that was doing maintenance on a gateway, stick a USB stick, and I got a call from my IT team saying, "Hey, man, there's an awful lot of traffic going on," and they were in our rack room. So I think I said this already. Your folks that are coming in from the outside, they're your responsibility. Make sure that you know who you're working with, what their level of technical expertise is. You're right. You should have that. What kind of credentialing do they have? I mean, like training and education. Do they have credentials to be able to work on the IT component, or is it just the X-ray system? Yes, Al.
Recently attended a local biomed conference that Herman McKenzie was speaking at. He actually said that is something that Joint Commission is going to be taking a much harder look at in the near future. Credentialing both with your own staff and also better have a handle.
Everybody hear that? Al was saying the Joint Commission with Herman has said his surveyors are going to start asking about that, about folks coming from the outside, as well as your own staff having the appropriate credentialing. Now, your in-house staff, just like the manufacturer, if there's OJT, that's perfectly acceptable. But document the training. Document the training. Great.
And that's for your contractors that are coming in too. You need to validate the competency of your contractors. So anything you have under service contract that has a field service engineer coming in, it's up to you to validate their competency. And that could be just a copy of their training records. That could be a letter from the manufacturer, from the OEM or the servicing company, but you need to document their competency as well. And I guess my last thing, because we're running up.
Yeah, we're getting close.
Here, but my last thing would be, is there a secret sauce to HTM department success? I think it varies, and it depends on, it's really going to depend on your facility. It could depend on the size of the facility. It could depend on whether it's an academic teaching institute or a level 1 trauma center or a critical access hospital. It's going to vary. Are there some things that should be standard throughout the industry? I believe there is. I think sometimes we're our own worst enemy within our industry. I think our industry's got a long way to go. By the way, Joint Commission's dropping the EP standards for AEM. Did you know that?
Yes.
Yeah, so it's going to be a guidance document, but anyways, use what works for your program. Don't be afraid to reach out to others and say, what are you doing in this aspect? And if it works for you, adopt it. If it doesn't, don't. So utilize what works for your organization, your department, to make sure that you're elevating that department and you're part of healthcare reform, part of the healthcare solution, and really creating a win for the patient, because that's who's important in the end.
You know what the secret sauce is? It's you. It's you. It's how you behave. It's how you give to yourself. You know, education, build your skill set. What kind of a leader do you want to be? The secret sauce is you. That's how we get there. Well, it's 5 o'clock. It's time to go get your costumes on and have some adult beverages or soft drinks and some great food. Thank you for attending. I appreciate it. Scan the barcode.